Hey class, today we're going to be discussing pre-hospital airway management. In this lecture we're going to cover why it's important, why it's needed. We're going to be discussing situations where you'll be needing to do some airway management, and we'll also be discussing some of the devices used, and then we'll review some of the basic anatomy as well throughout this lecture. So why is airway management needed in pre-hospital settings? Well, first of all, it's important to always protect your patient's airway, especially if they can't protect it on their own. Maintaining a patent airway is one of the top, goals that we have here. It can prevent aspirations. We want to try and prevent any, issues later on, aspiration pneumonia, things like that. And so that's another reason too we want to protect their airways. And then also too is a good patent airway can help with gas exchange, especially during working a code, trying to exhale some of those gas exchange. So to cover just a few situations that airway management would be needed, starting off, like I mentioned in the previous slide here, is a coded patient. Now with PICU CPR, you start your CPR, drop a King airway in, start an IO. Dropping the King airway in, we'll discuss that later on as well. But again, it's just getting the airway in, protecting that patient's airway, and then starting these ventilations. Head injury patients is another one. If your county allows RSI or DAI, is now what they're calling it. You'll need to intubate those patients as well, protect their airway, especially these head injuries. They can get some crazy respiratory things going on, decreased respirations, irregular respirations, things like that. Another one, respiratory failure, status asthmaticus. You could have exacerbated CHF, COPD, things along that, to where your patient, if unfortunately you get to the patient and you're behind the APOL already, you're going to have to do something with that airway if they go down on you. Another one too is upper airway occlusion, like our picture that we have here. This subject has a large fishing lure stuck in their upper airway. I would say removing that with a treble hook on the end of it would do more harm than good. And so, we'll discuss too about ways that we can go around that and fix that issue. So, types of airways for pre-hospital settings. Starting out with some of the basics, you have your OPAs, NPAs. You even have, just manual maneuvering of a head tilt chin lift, or even a jaw thrust if you're suspecting a spinal injury. The OPAs, NPAs, you can use those, very simple to use, all the way down to basic. You can use those as well, removing the tongue off the airway, opening that airway for them. Others that we can use too are the King airways. Those have been great, super successful with my experience, compared to combi tubes that, what I've heard. LMAs as well, they are used in pre-hospital settings. I haven't had a lot of experience with those, nor have I ever carried one on a truck. But we'll discuss that, later on as well. And again, to combi tube, I think that's one of the more common ones from the past. You have your dual lumens. You drop it, you bag one, doesn't work, bag the other one, see if it works, and go with the one that does work. Then you have your actual endotracheal tubes that you can put into a patient. And then most extreme case here too is a quick trach or a surgical crike. And again, we'll go into details some of that, but next we're just going to go ahead and start talking about the anatomy, do a little refresher of upper and lower airway anatomy. Alright, so here, again, just a basic review of our upper airway here. And we'll start out with just kind of pointing over some of the things. You have your nasopharynx up here, your oropharynx, starting here. The nasopharynx, we'll kind of talk about that a little bit later when we start talking about intubations and then DAIs, pre-oxygenating your patients. This is important to kind of understand too, if you ever have to do a nasal intubation, kind of what you're expecting, oral intubations, things like that. The tongue, always gets in the way, it seems, especially with some patients having larger tongues than others. So we want to keep that in mind too when we're assessing our patients. Again, you're coming back here to the back, you come down, you have your esophagus back here is where we don't want to be with the ET tube. We want our ET tube to come down this way. And down in here, we have our epiglottis. And you have a vallecula back here. And that's important to remember too, so when you're using a Mac blade, you want your Mac blade to come in here, hit into that vallecula. That's going to help lift up that epiglottis. Whereas a biller, we're going to go all the way in and lift up as well. So over here to the left, you can see the common, the white vocal cords here. That's what you're looking for. Now this photo is going to be reversed from what we're seeing in the field. Whereas us, we're going to look at it this way. The tongue is going to be up top. We're going to be using our blade. We're going to be swiping that tongue over to the left. We're going to be pushing forward, not rocking back, because we want the patient to keep all of their teeth here. So again, this is a little backwards, but you have your tongue right here. You can have your uvula sometimes hanging around, and then you have your vocal cords and your tracheal rings and all that stuff down there. The esophagus will be on the back side, the bottom, when you're looking at this, intubating somebody. And just the thing too, we have our cricoid cartilage here, our thyroid cartilage, and in between that will be our cricoid thyroid membrane. So that's also important to remember when we get later into this discussion. And so some patients are going to not have as pretty of a picture as this image here. This is the most textbook perfect kind of thing you'd want to see in the field. And again, some patients' tongues might be bigger, might have a larger uvula that hangs down. Their vocal cords might be a little bit smaller of an opening. And that's just when it's going to come into play about preparing your equipment, having your tube that you want to use, and then a tube one size bigger and one size smaller when doing this as well if you're doing an intubation in the field. And some patients, if they've had tonsils removed, those might be out of the picture. Personally, one intubation, the patient had some interesting growth on the inside, and I think we later found out the patient had cancer. So again, just anatomy is going to be different with everybody when you go to intubate them. And another note on that too is you'll always hear some medics say like, oh, they were very anterior, it was really difficult to intubate. And that is true to an extent. Again, just everybody's anatomy is going to be different when you're going to intubate them. So the next slide, we're going to go down a little bit lower into the airway and talk about some of that. Alright, so continuing on down the airway path here, we started out up here in the nasopharynx, and we're coming down. Again, you got your esophagus running back this way, and then our trachea here. You have your tracheal rings. Again, we're going to have that one space up here for our cricothyroid membrane. You're going to continue down the bronchi. It's going to split off to your right and to your left main bronchi there. And so it's just important to remember too when you're intubating patients, it happens all the time, is sometimes you can intubate too far, and your tube can either go right or left into a patient. So when you're bagging the patient, you might only have one side of the chest rising, vice versa, and you might have lung sounds over here, not over here. And so we always want to make sure that when we intubate the patient, we come back through, we listen to lung sounds on both sides, we look for chest rise and fall. And then some other indicators too that we've made it into the trachea here, past the vocal cords, is we're going to be looking for some things. Condensation in the tube, again, listening to lung sounds, and then capnography, putting the patient on capnography and just confirming our placement there. Because you just don't want to have a right-sided main intubation only ventilating at half capacity here. It's not going to be very beneficial to our patient if it's really needed. And so just always a reminder, check your placement before you secure that tube. And that's another important thing too, is securing the tube, is use your tube holder. Make sure once you get your placement, never let go of the tube once you intubate. Once you intubate, hold onto that tube because you don't want the patient moving, getting knocked, and losing your tube. So hold that in place. Make note at your mark. If you're 7.5 and 23 at the teeth, make note of that. Have somebody write it down. Put it in the back of your mind. Don't forget it. And once it's confirmed, secure that in place so you don't lose placement of that. And again, just keeping an eye on your capnography, waveform, and lung sounds is going to be make this whole treatment successful for you and the patient. So next we're going to go ahead and start talking about applying and using some of these devices in our patients that we might encounter. So using and applying these airway devices in our pre-hospital setting, we'll go ahead and start with our most simple ones, is the OPAs, NPAs, head tilt, chin lift, and a jaw thrust. So again, like jaw thrust, you would want to use on a patient with suspected C-spine injury, somebody in a crash is unresponsive. You don't want to sit there and do a head tilt, chin lift on them, because you could just worsen a injury that they have that you can't see. And so, the head tilt, chin lift, somebody that you're not suspecting, not a traumatic injury, perhaps, somebody coded in their bed, so you're not suspecting a code into a fall or a traumatic crash. So let's say you have a patient, with snoring respirations, and they have a gag reflex intact. And if they have a gag reflex intact, let's say you're going to put an OPA in, as soon as you put that OPA in, they start gagging, go ahead and take that out. Don't leave that in there because we don't want them vomiting. Again, we're trying to protect their airway. We don't want aspiration going down into their lungs. So if they do have a gag reflex, you can drop an NPA in there, in their nair. And there's some doctors out there through the emergency airway book. I'll have to get the exact name for that, but they even recommend that if you could, and all you had was 2 NPAs and an OPA, you can drop that in your patient and bag over that if bagging is needed. Also, choosing the right size of each of these is very important, and we'll discuss that later on when we get to the hands-on portion. Caveat with the NPAs is, it's always taught that you need to be concerned with skull fractures, basilar skull fractures, and then that NPA going into the brain. Last I've heard, it was only 2, maybe 3 actual documented cases of that happening to people. And so the key is like you're always taught with NPAs, is when you're sliding these in and putting these in place, if you meet any resistance, don't jam it, pull it out, try the other side. And again, if that doesn't work, then you can just resort to other options. So don't jam these in there. Don't try and forcefully put them in there. You want the NPAs, you want them lubricated to put them in. And so let's say you don't have a packet of lube or for your NPAs, and the patient has like excessive saliva. It might be barbaric to some, but you can use the patient's saliva to lubricate the NPA prior to putting that in there. And so the NPAs are going in. They have snoring respirations. They're typically snoring because the tongue is resting back on their throat. So these NPAs and OPAs are going to go into the naso or oropharynx. We're going to lift that tongue off of the back of the throat, open that airway, and really help with the ventilations of the patient. And again, these are right here. These are some of the least invasive procedures that we'll be doing for airway management and pre-hospital airways within EMS. And so next we're going to start talking about the blind airway insertion devices, BAIDs, in this next slide. Alright, so let's talk about the blind airway insertion devices. It's going to be a step up from our OPAs and NPAs, a little more invasive here. The most common one really is going to be your King Airways. As you can see here in the middle of our slide is our King Airways here. And earlier I made mention that the ET tube we want going into the trachea, whereas these King Airways were designed once you drop them in, it goes into the esophagus, occludes that off, and when we bag, air comes in, comes out through here, inflates the lungs, and helps with the gas exchange. Each one of these tubes, they were smart enough, they went ahead and put the amount of air needed to blow up these balloons so we don't have overinflation or underinflation of these balloons, and we can really get a secure airway in place. And some people too have taken these. You can drop a bougie through here. It's a little tricky. Let's say you wanted to get a more permanent airway in place, like an ET tube, and they were a difficult patient. Let's say no neck, beard, no teeth, very anterior, large tongue. Let's just say all of those. So you could take a bougie, drop a bougie down, and the tube, and it's going to pop up through here into the trachea. And then once that's done, you can shimmy the king up the bougie, keep the bougie in place, drop your ET tube over the bougie, and get a more secure airway in place. And again, the combi tube, like we may mentioned earlier, is a dual lumen tube. Again, you just drop it in, you'll inflate your cuffs. And the first here, you can see that when they dropped the tube, they went into the esophagus. And again, what you'll do is you'll drop this in, inflate your bags, and you'll blow, get your BVM, ventilate through one tube. All right, and if that doesn't work, you don't get lung sounds, you'll go to the next one, ventilate through that. And if you get lung sounds with that one, you're going to keep your BVM on that lumen there, and you'll clamp off the other. And then, this one, this is just showing that when they dropped the combi tube, it did actually go into the trachea here. So again, just same procedures. You're going to ventilate each one, find the one that is giving you lung sounds, and you're going to keep going with that one. And then over here is the LMA. Again, not common. I've never had to use one of these in the field. The same thing, you're going to drop this thing in. It's going to blow up and go around the trachea here, and that's what's going to help bag the patient. So again, these are just a couple of the blind airway insertion devices that can be used. And again, with the whole new pit crew CPR being taught, King Airway is just dropping that airway, getting that airway in place, starting ventilations during your CPR. Early gas exchange for these patients is really important. And so the next one we're going to be talking about is our ET tubes or endotracheal tubes. Alright, so ET tubes, endotracheal tubes, these more definitive airways that we'll be using for patients. And again, we can use these if it's a coded patient, prolonged transport, and we're able to get an ET tube in, we can use that. Perhaps your service only carries ET tubes, and this is your only means of doing it. Again, the ET tube, this is going to be directly into the trachea here. We do not want this going into the esophagus. This is a single lumen. There is no dual lumen. It's not gonna. You're not gonna have the option of trying to figure out which one to bag through. And so this right here places it directly into the trachea. And so when doing so, you can do, as I mentioned earlier, you can do an oral intubation, or you can do a nasal intubation going through the nose on some of these patients. And the nasal is going to be a little bit more difficult than the oral intubation. And so our oral intubation, we could do a visual using a handle with a blade on the end, or you can use a camera like a glide scope, a King Vision, to help visualize that as well. Or you could do a digital intubation. For some reason you're in an austere environment, you don't have a blade, or your blade got lost. You can always do a digital intubation using your fingers and dropping the tube through. And now you want to always, when intubating, there's a couple things. You really want visual confirmation of your vocal cords, the tube passing through the vocal cords when intubating. And as mentioned previously, when you're intubating your patients, you're going to be looking for a few things. You're going to be looking for the condensation in the tube. For the ventilations, that's going to really kind of be a good sign. Adding capnography to your tubes once you get them in place, and that's going to really show, okay, here's some waveform, here's some CO2 getting blown off from the patient. And that's just a couple things that you want to do. And again, like once you confirm that these are in place, you want to secure that tube properly in place. We carry the ET, Thomas tube holders, fits around the tube, kind of clamps it down, holds it in place, wraps around the patient, back of the patient's head, and secures it. And again, we want to make note of tube size and tube location at the teeth. So again, if we're doing a 7.5 and we go 22 at the teeth, we want to make note of that. So during transport, if we look down and we see that we're at 27 at the teeth, we might want to reassess our patient, because now we might have like a right side or left side main bronchi intubation, and we're not fully ventilating this patient. So proper placement is super important when it comes to ET tubes, whereas the blind airway insertions, you just kind of drop it and forget it. whereas the ET tube is a little bit more, it needs a little bit more accuracy involved with this, and so practicing these makes it a very valuable skill. And as mentioned, the King Vision, it's kind of the new thing, whereas like old school laryngoscopes with your little light on the end of it, it seems to be getting faded out. There is some controversy on that to where medics are losing their skills by not being allowed to use that. But if you go off of like statistics and stuff, there's a lot of failed attempts of intubations in the field. Medics are taking way longer than they should to intubate, and you're even seeing that personally. You can see other people, instead of only taking a few seconds to try and pass a tube, they could be taking 20, 30 seconds. And as we know, we need this gas exchange, especially during CPR. And another thing too is you don't want to stop compressions during intubations. You don't need to. Every time you stop compressions, every few seconds you lose a percentage of ROSC with these patients, and so again that could be detrimental in the long haul if you do 2 or 3 intubation attempts on these patients. And so it is good to know your equipment and make sure that you can use it properly. And so in the next slide we're going to be talking about passing the tube a little bit more in depth. So as mentioned before, I talked about the old school laryngoscope and these new King Vision. So on the bottom here we have our old laryngoscope with a Mac blade. I'm not sure, some of these have LEDs, like little fiber optics that come through the bottom. Some of them have old light bulbs that I've had on trucks before. And on the top here we have the King Vision. I was fortunate enough to have this on a truck working at another agency, and I can attest to these things being the bee's knees when it comes to placing tubes. Again, as you can see, starting image 1 is coming in, number 2 is coming down closer to the vocal cords as seen there, and number 3 you can just see this beautiful clear as day picture of the vocal cords. And these King Visions are great because it has a place for you to place the tube in a channel, and so when you're intubating, your tube's already right there at the tip of your camera typically, so you can see the tip of your tube. So when you're pushing that tube through, you can have that direct visualization of your tube passing through the vocal cords. And again, that's like one of the the top confirmations of oral intubation with your patients is, okay, hey, yeah, as you're walking yourself through it and you're talking to everybody, you're letting everybody know, hey, visualization of the vocal cords, passing the tube through the vocal cords, okay, I'm in, removing your blade, holding the tube, and again, not letting go of that tube because we don't want to displace it now that we have it in place. And again, once you get that in there, you pump up your balloon with your syringe. Now you can start ventilating. When you're ventilating, you might see some condensation start rising through the tube. And again, putting capnography on, it can be forgotten at times, but always remember to put that capnography on your tube, in between the tube and your BVM, and looking for your waveform, looking for your rise of capnography on your monitor as you start ventilating. And again, the other thing is lung sounds, is just auscultating lung sounds, looking for chest rise and fall. Now with a traumatic arrest, you ventilate, and let's say you have proper placement, the patient may have a pneumo, and so your agency's protocols may be allow you to do certain things. Some agencies will allow like bilateral needle Ds, but again, that's just going to be situational and departmental on whether or not you can do those things. And the hospitals, going back to the cameras, hospitals, if you're in a hospital working at ER, I'm sure they all have like the glide scopes, and again, it's just having these cameras can really attest to the successfulness of that compared to just a laryngoscope and a tube. And so doing all these things properly, again, is going to be super beneficial. And another thing I want to hit on is when we're intubating and we're passing the tube, a couple of things we want to do, for our patients. I had an ER physician one time talk to us that putting a nasal cannula on the patient at high flow O2, you're pumping 10, 12 liters through this nasal cannula, is what you're doing is you're filling up their nasopharynx. You're filling up all of this with 100%, like almost 100% oxygen at this point. We're just pumping so much in there. And, you want to bag your patients too. You want to do this nitrogen washout. You really want to build up their oxygen before you stop ventilating these patients. And so it's just a thing that's still practiced with me is putting a nasal cannula on these patients to create that high flow oxygen, build that little oxygen reservoir up here in this nasopharynx or sinus cavity, because there's just such a huge space up here. And so, when you bang that patient, you're pushing down. Well, when you ventilate, all this is going to get sucked down as well too, get pushed down into the respiratory system and allow for greater gas exchange. And so, again, just to summarize here, you want direct visualization, you want some condensation in the tube. Don't forget your capnography, and always listen to lung sounds. If you have gastric distension during this, but you still have good lung sounds, you can always drop an OG tube down on the patient, because your tube is in the proper place. So, that being said, your trachea is occluded with your balloon and completely secure. So your OG tube is going to slide right down into the esophagus, down to the stomach, and you can release some gastric distension as well. So the next slide we're going to go into is we're going to start talking about crikes and some of the situations we could use those in. Alright, so cricothyrotomy, surgical crikes and quick trachs can fall under this. Previous agencies and even this current agency, we are not allowed to do surgical crikes, and I think it's because they're messy and there's been a lot of failures with them within the field. So we'll just kind of skim over surgical crikes and talk about those, but we'll talk more about this quick trach as seen here in this top photo. Kind of all in one kit, very easy to use compared to a scalpel and the trach hook, and then opening the trachea and dilating it just to get a tube through. So again, as we talked about earlier, our anatomy here, we have our thyroid cartilage. Now this right here is going to be more prominent on biological males than it will be females, so it's going to be a little bit easier to locate on males. And so below that we have our cricothyroid membrane or ligament here. This is where our target, kind of where we're going to be going. And before that is our cricoid cartilage. And so up here in this upper trachea, this one little soft spot is our go-to spot when we're going to be doing these quick trachs or cricothyrotomy surgical crikes. We'll just skip over the surgical crike real quick. So, and why we're going to do this. So let's talk about why. Upper airway occlusions. That could be somebody has swallowed something, or in the earlier slides we had the mannequin with a large fish hook stuck in his mouth with probably a treble hook on the inside. So that's not something we want to just rip out of the patient's mouth. We can cause way more damage than good. So upper airway occlusion could be from a severe allergic reaction. Patient's throat could have swollen up. Some things you can hear, maybe a stridor during this. And so at this point, we may not be able to pass an ET tube through this patient if they were needing an airway put in place. And so, the last resort kind of deal is going to be a crike or a quick trach for these patients. And so with a surgical crike, you'll have a kit, potentially have a kit. And, the biggest thing really is locating your landmarks here. So you want to go down on your patient, you're going to find their thyroid cartilage, you're going to come down, and you're going to find this cricoid thyroid membrane right here. Now, some people will always carry a Sharpie on them, and so it can always be good to sit here and put an X, maybe a little cross here on the cricoid thyroid membrane, letting yourself know where it is. So if your finger slips off and you lose it, you know where it's at. And so we can mark that spot with a marker. And so what we want to do is we want to take our scalpel here. The first incision you want to make will be vertical. Some people will want to go across, but you don't, because you do have some vessels running on each side of the trachea. So again, the most important thing is you want to make this vertical incision right here, right across your X. And once you have that vertical incision done, it's going to be very, it's going to be pretty messy procedure here. You're going to have to open that vertical incision up. And once you have that vertical incision up, you're just going to make a little horizontal incision, that cricothyroid membrane right there. And some people will take the backside of the scalpel and just push it through and twist it. You can have a dilator. You can spread that open. And some kits have these metal dilation tubes where you start with a small one, work your way up, dilate it to where you can get a tube through there. And once you get that open enough where you can push a tube through there, you're going to push a tube, blow up your balloon, and then you're going to listen for lung sounds. And again, you're going to want to secure this tube in place. You're not going to want to get it lost. This is probably one of the most severe ones where you do not want to lose tube placement, especially with the very invasive procedure that was done. So in my time, it went away from that, and the quick trach here was brought out to us. And so with this quick trach, again, you still want to find your landmark. Again, that's always going to be important for this. And really with any procedure, with some of your patients, just finding your landmark. So again, me personally, I like markers. You can mark your patient. It will come off eventually. But again, just being 100% sure this is where I'm going. And so with these quick trachs here, again, you can kind of see there's like a needle, plastic like catheter over that, and this is a little red piece right here. It's kind of like a safety device to prevent you from going all the way through the backside of the of trachea and into the esophagus. And so with these, there's no scalpel needed for this. It's just you're going to find this, take this in, get your landmark. You're going to kind of go in down towards at an angle here, and then you're going to pop through everything. Once you get popped through everything, you can remove the needle. The needle is attached to the syringe here. Another side note too of the syringe is when you're popping through, you can pull back on that syringe, and once you get into that trachea, that syringe is going to allow you to draw air into it. If you're not drawing air, you're probably not in the right spot. And so again, once you get this popped through, you kind of push down right there to the red safety cap. You can pull everything out, remove the cap, and then fully seat the quick trach in place. Again, you can attach capnography to this as well as a surgical cric. You can attach capnography to this. You're going to want to listen to your lung sounds. You're probably not going to see much condensation just due to the short real estate that we have here. But again, lung sounds will be important, capnography, and rise and fall of the chest. And so this is really kind of covers some of the basic to more advanced items that we have as far as airways that we have in pre-hospital settings. And so next we will go over some hands-on portions and go over just some skills on what we can do with that.